please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
Hi.
Hi. I have so much to talk about.
Oh, me too.
We always do.
We got to do the podcast last week at IFM.
That was so much fun. I can't wait till it's up because the optics of like just where you were, I always feel like I'm where you are, but it was so great to see you at that platform.
With the forklifts going by. And
nobody saw the forklifts, but we'll take your word that they happened in front of you. But even with you, with all your ADD-isms, I'm proud of you.
Thank you. And then the next 2.5 days, it was like old home week.
Yeah.
And remember Michael Stone from IFM?
I'm not sure if he's one of those people. It was like Dave Burke. Like when Dave and I finally met face to face, it was like, but we've known each other for years, but we actually haven't because it was through you. So I'm not sure if Michael Stone is also one of those people.
Michael Stone was in practice in Ashland.
Okay.
And when I took AFMCP the last time, so I've taken the 5-day functional medicine course 4 times now. And the last time I took it, Michael Stone did a physical exam for functional medicine, internal medicine sort of complaints. So what does their skin feel like? What does it mean when they stick out their tongue and it looks like this? How do you look at their eyes? What do fingernails, eyes, just the physical exam. So starting about 6 or 7 years ago, I said to Michael, you really need to come do that for the FSM group. Oh yeah, I'll do that. So he's blown me off about twice, and then I tried again, and then I gave up for a couple of years, and then this time I met him face to face, and I said, are you going to come do that course for me? And he said, yeah. And you're not going to blow me off this time? No. So he's going to be at the advanced, and we can't decide whether he needs 90 minutes or 3 hours. Depends on how much practice people want to do on each other. So
Right.
We will have 150 tongue depressors and cotton swabs or whatever. And that was really exciting. And I got to see Jeff Bland and Christy Hughes. And it was like, oh, and Jared Pollack was there. It was like old home week. It was really fun.
I'm glad. I could feel your energy and your excitement when we had our podcast last week.
And then, I don't know what your theme is, but my theme for today is don't ever give up. So somebody came to the booth that has had atrophy at L5 and S1, had foot drop on his right leg. And I said, that's not that hard. So he laid on the table and I just ran 40 and 396 and 81 and 396, increased secretions in the nerve. And his calf plumped up a bit and the muscles started to operate. So then we connected his brain to his foot. And then we had to take the scar tissue apart. So I treated him twice. And at the end of the first one, we taught him how to walk. And at the end of the second one, taught him how to walk and figured out that we had to get the sciatic unstuck because his hamstring wouldn't contract. He could put his heel down, but he wasn't bending his knee. Now it's been 7 years since he had this spine surgery thing. And I said, you're not bending your knee. So we took apart the hamstring and took apart the scar tissue and then exercised his walk.
Mm-hmm.
And by the third day, he went to the gym in the morning and came by the booth, and I was working on somebody's vagus nerve. And he just left me really yummy scented soaps and said, thank you, because I went to the gym and I went for a walk.
Ah,
So it's never not possible.
okay, you're right. And this really does go well with my sort of theme. Even if it doesn't, I always make it work somehow.
Oh, good. Of course you do.
But my sort of trajectory that I wanted to plot today's course on was, and I'm going to use the word stubbornness to take a diagnosis that doesn't feel right and get a second opinion or a third or a fourth or whatever, and find a person that is going to listen to you and whose prognosis of whatever condition you have, A, makes sense to you, and B, feels right.
And I'm going to add to
Please.
that, because of how FSM practitioners are trained, we can be the second opinion.
Yep. I have an inherent disdain for practitioners of whatever discipline that tell a person to stop moving.
Why would you do that?
Right. But the goal should always be to keep moving.
And in our world, to make the movement more normal.
Correct.
But one of the people that came to the booth, she said, yeah, I can't do this. And I went, that's your QLs. Are like, yeah, it hurts right there. I went, okay. When did you fall on your back? Excuse me. Here, lay down. This is your ow. So yes, it's scarring in the ureter. Excuse me. Yeah, I know. And we did scarring in the ureter, and then scarring in the kidney, and sclerosis in the fat pad. And as her right-sided ribs began to rock, I said, now take a deep breath. I can take a deep breath. Yes, keep moving. And now whatever you were going to say, I'm really sorry.
Okay, I got to back things up to hamstrings for a second, because
Okay.
one thing I want to highlight, and I'm sure all the PT-ish people who are listening to that were like, okay, if he can't bend his knee, the scarring is in the quad. No, but that can happen. If there is scarring in the quad, in the extensors, right, the antagonist, the primary mover is knee flexion. If there's scarring in the quad is tight and it's not allowing for the knee to bend. So
Then
that
it's scarring in the femoral plexus.
right. So
Right.
that's one way of looking at it.
True.
So this is why I walk people back in this sports course, and they're always like, oh my gosh, this was like first year PT school. Why are we talking about this? But your active, passive, and resisted testing is going to really help you troubleshoot. Is it scarring in the antagonist preventing the movement from happening? Or is it a quote unquote weakness, or as we say, is it inhibited? So if that's a quick test, you're doing your passive range of motion, okay, it's not moving, something is preventing it from happening. If your passive testing is symmetrical, and then you're doing your resisted testing, then your resisted test, oh, it's actually showing up as being quote unquote weak. Now we know hamstrings are inhibited. Then your next question is, don't settle for weak hamstrings. Don't settle for weak glutes. Don't settle for any of this stuff. Your next question is why? Why are the hamstrings weak? Is it coming from something like adhesions? Because we will never let a nerve get traction to the point of tearing, right? That will shut down. If there's an adhesion there, we're not going to allow for that contraction. Or is it happening higher up? Is it a disc problem? Is it something from the cord?
Yeah. And for him, actually, it was a hip surgery.
See? So
he had bleeding, and they did it from the side, so it bled down. So the first day I took apart the femoral plexus, and then that worked. But when he was walking, he wasn't bending his knee. when he walked.
Right.
Was the habit, was the hamstrings. I reached up in that groove where the sciatic is, and there was this sticky spot where the sciatic should glide,
Right.
and you go up in there and start prying it apart, and it's no. So I took it apart.
And again, this all goes back to like the basics at nauseum, taking a very thorough, comprehensive history so that you knew about the surgeries and you knew about everything to look for. You do your physical exam, and that's just reaffirming what your hypothesis could be from the history. And then you've got your palpatory skills that also confirm what your active, passive, and resisted findings are showing. Because let's face it, we're not going to run a treatment for 5, 6, 7 minutes and then do active, passive, or resisted testing when you can just feel for it.
And for those folks that are listening, what I'm going to suggest is don't be afraid, don't be scared, because your palpatory skills will improve.
Yes.
It's like I'm a chiropractor. They spend 2,500 hours in 12 months teaching us palpation. Actually, it's 2 years. And then that's just the start. So as FSM practitioners, one of the things that's different about us is that because the first skill set that we learn is to be light and to feel and to watch people's face, the physical therapists and the osteopaths and the manual therapists, the massage therapists, and the MDs and internists and folks who say, wait a minute, can you place a central line? Of course, because they made you do that in residency, right? Yeah. Okay. Then you have better palpation skills than I do.
Right.
Think about finding the edge of an artery.
Right.
Oh, okay.
Yeah.
So the key is don't be afraid.
And I know we talk about safety every single episode, but to feel safe with your palpatory skills, and I think we've done such a good job of slowing the practicums down, because everybody gets into the practicum, they're so super excited. They want to feel this motion, they want to do this, and they want to do this, and where do the leads go? Red and bumblebee and Christmas tree, and that. And everybody sit down, take a deep breath, right? Relax your hands. You're going to learn. And again, it's all about sensory versus motor. You're learning what smush is by feeling the changes. I believe it's the fascia that tells us the first set of clues. That's what I feel smush to be, is when something tight and hard and viscous becomes clear and defined and open.
What's that fluid word that you use?
Thixotropy.
That one. Yeah.
Yeah. So thixotropic changes is what scientifically does happen with fascia. That's not an opinion like that. You could look that up. And once I learned that and I saw that concept and I reread that chapter in Tom Myers about ground substance, like to me, and I think every practitioner out there has to form their own like narrative of what we're feeling. And it doesn't matter what that is, so long as you feel for that every single time. And that's your baseline.
And what's fascinating is when we get to the end of the supine cervical practicum, and I say in my tone that is meant to aggravate John Sharkey and the fashionistas, okay, now that the muscles are all smushy, run 91 hardening in the fascia. Does anything soften? And everybody's no. Okay, now run increased secretions in the fascia. And the look of surprise, disbelief, somebody at the last practicum said, I didn't think it could get any squishier, but it's like it just turned to gravy.
I say snot, but
No, I was gonna say snot, but that sounded just a little disgusting.
it sounds
So
gross, but that's what it's like. But, and when you think about, and I like 49 also with the fascia increasing vitality. And I think as we're learning more and more about fascia and its neural conduction and its stored energy, it makes sense that increasing vitality to that structure would have those changes, would have that flexibility, the thixotropic changes, however you want to frame that. So again, going back to the hamstring, when you do a gross anatomy lab of the hamstring, and to me, that was one of the most shocking structures that we did. I'm like, the arm looked like the arm, but the calf looked like the calf. But when I tore apart the posterior upper leg, I was like, what do you mean the hamstrings aren't in 3 cute little bundles like they are in netters? What do you mean they're gummy and they're enveloped and there's fascia and adipose and vessels and have
arteries and nerve, that a nerve that's this thick. Have you ever seen Body Worlds?
yes.
Okay, the one where the hurdler is going over the hurdle with his leg outstretched and they dissected out the hamstring and the nerves.
Yeah.
I sat there and looked at his ischial tuberosities and down to his knees, holding up this whole line behind me in Atlanta. And that is not, and then you look at the other hamstring with the leg bent behind.
Yeah.
And that is not how exactly.
Yeah.
You're working on the hamstrings and you have to think about down at the knee, right where they attach. And because we're us, I look for tone in the quads and the hamstrings, and the place you feel the increased tone in the hamstrings is down just above the attachment at the knee, because there's a tendinopathy because the hamstring is so tight.
Yeah.
Then when you are working on a patient that's, excuse me while I put my hand in your butt, because that's where the hamstring attaches, and there's 18 burses in the hip and the pelvis. And it's just magic.
Yes, it's magic, and we are magical. And as we're talking about the hamstrings, I'm having this flashback of college when we're taught, and like I said, I have nothing but good things to say about the type of training that I had. But when you're a manual therapist and you're taught how to separate the hamstrings and we're ripping apart the adhesions in between the hamstrings, and you can feel the adipose like pop, pop, pop. It's like bubble wrap going underneath your hands. And you think you're doing such a great job.
I know, it's so bad.
And I'm not saying I don't do manual therapy that's very similar to that, but the approach and the intent is completely different.
And during the core, the trick is to teach people to think in 2.5 seconds, to follow the frequencies as they soften the scar tissue.
Right.
And the manual therapists have the worst time, the poor things, because they're used to, let me tear this up. No, just wait.
Totally.
Feel it soften. Oh yeah. Now move 1 centimeter, wait 2.5 seconds, 5, move it, wait, move it, wait. And it's almost like following, like surfing. It's like surfing the fascia, surfing the nerves, surfing the scar.
Yeah.
It's so cool.
Patience is the name of the game, right? I remember years ago praying for patience.
No, you didn't.
The universe gave me FSM, but it has been such a beautiful journey learning patience, because if you can't force competitive distance running, you can't force a pace that's not going to be there, and you can't force tissue to do something that it's not ready to do. And so when I explain, I had just a whack of brand new people come in the last little while, and it's not a spiel, but I talk about, we have a timeline. The patient has a timeline when they come in, and for athletes, it's yesterday when they want to get better. They have zero patience. Chronic pain patients have been through it all. They have no patience. Us as
Well, the thing is, they don't expect to get better.
okay, and
Everybody else has failed.
yeah, why are you any different?
Yeah.
And the exuberant FSM practitioner also has no patience because they think they know how to fix it in 20 minutes. And
Yeah.
then there's reality. And then there's what the tissue is going to decide to do. It's the he said, she said, and then the reality in between the two.
And just to take us out of the physical medicine realm, I had a patient this week whose goal, like she's basically a wicked athlete. She's in her 60s, so she's not the kind of athlete she was in her 20s, 30s, and even 40s. But her complaint is that her resting pulse was 78. And it's like, that's normal. No, it's not. My resting pulse is 60. You don't exercise as much as you used to, blah, blah, blah. And she said, I had COVID. Oh, okay. And that was it. It's like, that's when her pulse went up.
Okay.
And she said, what do you do to fix it? And it's just COVID. And it's vagus nerve. It is the thing that slows your heart rate. And the vagus is turned down by infection, stress, and trauma. And so you don't have COVID anymore, but the vagus signaling has been changed by the effect of these 6 viruses. So I ran concussion in vagus from her neck to her abdomen, and I ran on a precision care each of the 6 virus frequencies on the vagus and on the heart, just in case. And her resting pulse went from 78, it was down in the 60s, and then it bumped back up to 70. She came in the second day, and after the second treatment, her resting pulse was 58. So it's not always a one visit fix. And you always have to ask, where did it come from? It's like, when did your shoulder, hip, back, gut, brain stop work change? I've always been like this. Really? Okay.
So a couple things to unpack with this one. So yeah, asking why and when, whereas some people are just so super okay with the history. I had COVID. Okay. No, let's figure this out, and explaining about the vagus nerve. And I think you've done such a good job of educating us to not be afraid and to just be aware that I call it Lord Vegas in my clinic. It's the governing body right now.
Really is. Once you see it, you can't ever unsee it.
And the fact that it's just not about on or off. And we hear so much about vagal nerve stimulators and all these other things, but it is not a switch. It is, but why is it switching on and off the way that it does?
In the exhibit hall at IFM, there was this booth that was selling an external vagal nerve stimulator. And somebody came by and asked me about it. And I said, what turned your vagus off? You can turn it on, but your hippocampus and your midbrain is going to turn it down. It's never off. It's going to turn it down faster than you can turn it on. So you can run your vagal nerve stimulator 3 times a day, and it's not going to stay on until you address what turned it off.
The analogy I heard the other day was like a breaker, right? If the lights go off, you go around to the breaker, flip it back on, you're doing all these things, goes off, run out to the garage, hit it again. It's
a great analogy,
isn't it? No, you need to stop and figure out where the electrical circuiting is flipping out and fix that.
Yeah.
I see that. And the vagus nerve looks like a freaky electrical like wiring from the 1960s. So I think about that a lot. And so I see those vagal nerve stimulators as just somebody flipping the breaker. And yeah, maybe it works, but
The thing is, it's what they can do. Our job, because we live in the FSM world, is what happened? What do you mean? When did you start having inflammatory issues or autoimmune issues or rapid heart rate or reflux or irritable bowel? Or if you look at all the things that the vagus does, when did that happen? X year. Okay, what happened 2 months before that? The patient said, let's just go back. And once you find out what it was, there's a difference between getting pneumonia, getting COVID, being raped, getting in a bar fight, getting a head injury, having a rollover car accident caused it. I'm seeing somebody next week where she had some pre-existing stuff, but she had an auto accident, and her mom is a friend of mine. And she said the girl, who's about 16 now, is nauseous 24/7. And the thought, the smell of food makes her nauseated.
wow.
And it has to be the vagus nerve. When you look at where the seatbelt goes and what happens when a car accident happens, mom's a physician, so she has checked everything else. And when this person emails me and says, I can't figure it out, it's got to be Vegas.
Yeah.
So next week I'll find out if I'm right. But
And that makes sense, right? And it's totally worth a try when you have a hypothesis like that. You see the dog can open and close the door.
yeah, the dog can open the door. It's like, great. And mom's busy, so she's not going to catch me.
Yeah, and then the other dog comes in and it's a thing. Again, I feel like you bring us and then I bring us back and then you bring us and it's a wave. We're going with that surfing analogy today.
Yeah.
That I like. So again, you can't force the tissue. You can't force the vagus to work better than it's going to work in its environment. And when you're talking about trauma and all the things of what could have led the condition, whatever condition that is, to get worse, do you want to make a note? Like, you have a very interesting background, because between your pharmaceutical knowledge and your psychological knowledge, you're able to pull from both of those backgrounds and bring that into your treatment. And not all of us have that. And especially with the trauma stuff that a lot of chronic pain patients, autoimmune patients, even athletes have, when you are asking them, when did this start? And as long as you've been practicing with it, you can see it in their eyes when it started. And sometimes they're not willing or ready to verbalize what happened. However, you don't necessarily need to have a counseling session, right? The fact that they can go there sometimes can make all the difference in the world with the treatment. So I would have somebody that said, okay, I know exactly when this started. Their eyes close and their breathing changes. And I'm like, it's okay. You don't have to talk to me about it. I just trying to figure out how this could have started. And then everything just starts to relax. We don't have to fix it all, but we're just bringing light to that dark shadow that perpetuated something. And that can be a real beautiful moment.
it almost always is. Yesterday, I had a new patient, and my new patient visits are usually 3 hours. It took me 3 hours. She didn't do a timeline. She did, but there were no dates. And there are people who are linear. It's 2006, and then I had my kids in 2012 or 16 or whatever. Her history was what you call tangential. It was like a pachinko machine, or one of those things where you throw 100 ping pong balls on a trampoline and watch them all go like that.
Yeah.
And it took me an hour to figure out that she had a vestibular injury.
Oh, wow.
And she can't track. She can't put things in linear order. And when I did the physical exam, I put the tuning fork in the middle of her forehead. She's really stoic. Once again, an athlete, really stoic. And I said, where do you hear that? And she said, just this year. Oh, interesting.
Wow.
Put my finger up, and she's saccadic on that side. It wasn't until during the treatment that she said, when you put your finger out in front of my face, I get nauseous when somebody just puts their finger there, because every time I have to follow the finger, it makes me nauseous. And I said, have you ever told anybody that it makes you nauseous?
Yeah.
No. So then I explained what a vestibular injury is, and it's not what she was there for. What she was there for was her lower extremity.
Yeah.
But what's wrong is her BIVSS score is 46 over 18. It's okay, we'll talk about that tomorrow.
Right.
And it's just, they come in as a whole package.
Yeah.
And I felt stupid. Took me an hour and a half before I figured out, I bet she has a vestibular injury.
When there is so many ping pongs to look at, and you are in the business of pattern recognition, sometimes you can't see the forest for the trees, because you go on a trajectory of, oh, I bet you these are all related. And then you get like a red herring and you're just like, okay, that doesn't fit. And then again, more ping pongs. And then.
And it had nothing to do with her primary complaint, which is Tarlov cysts.
Okay.
And our goal is to prevent her from having to have surgery for Tarlov cysts. I had to look up what causes them. What are they exactly? I finished my research last night after I got home.
Hey, share what causes them.
That's a really good question. The medical community thinks they come from space.
Yeah.
But it's interesting. It's any place between 2% and 25%, depending on which paper you read, that are asymptomatic. So if you had 100 people, all with MRI confirmed Tarlov cysts, and for all of those of us who didn't know yesterday what a Tarlov cyst was, it is an outpouching of the meninges around a nerve. It can happen in the spine, but the ones that are really problematic are the ones in the sacrum, because they cause bladder dysfunction, bowel dysfunction, pelvic pain, sacral pain. And for her mechanism of injury was she fell, and I believe 8 years ago, for her left SI joint. And the Tarlov cysts are primarily on the left, and they're huge. They're a centimeter and a half, and there's S2, S3, S4. And
what's typically done for them?
That's bad. There's this surgeon, neurosurgeon that she went to, and she's from the South, and she's really smart. So she looks up what's wrong with her, and then she goes and tells somebody what they need to do. Anyway, so she had a bulging disc in her low back and got sent to this neurosurgeon. He spotted the Tarlov cysts and told her, I'll answer Kate in a second. And he told her, oh, we'll do surgery for that. So what they do is they take off the top of the sacrum, and then they go in and they rubber band around the Tarlov cyst to squish the fluid out. But the only other Tarlov cyst patient I saw was where they were worse. 25% of patients are worse after that surgery. 60%, that's really high, because once it's bad, there's no way to unbad it.
Right.
It is really bad. So I figured the Tarlov cyst had to be meninges. So I ran inflammation and congestion in the dura, all alternating,
Mhm.
inflammation in the nerve, torn and broken in the SI joint in the connective tissue. And then she had a painful spot at L5 and the ball of her foot hurt. So a little bit of S1. And so I ran from low back down to the feet with just inflammation in the nerve. She got up off the table and said, I don't have any pain now. So then I came home and looked up that there's actually scarring in the arachnoid around the nerve root,
Right.
around the sacral nerve root. It gets trauma. So the medical literature says Tarlov cysts are associated with trauma. A torn SI joint counts if you look at where the nerves go. If you're going to get trauma, that could lead to bleeding. All it takes is 1 or 2 spots of blood. So tomorrow when she comes in, we'll do scarring in the arachnoid and see if, because the arachnoid has as its job to reabsorb CSF,
Mhm.
reabsorb the fluid that's around the nerve in the meninges. So tomorrow I'll find out if doing scarring in the arachnoid, you guys understand that I've never seen a patient with an active Tarlov cyst, much less 6 of them, one of which is 1.5 centimeters. So you take what you know, which at that point was nothing, like I'm working on her and having my phone open and Googling what causes them, what are they. Then I found out it's okay if it's scarring in the arachnoid. That actually makes sense because the arachnoid is what is supposed to reabsorb the fluid.
Right.
If it's scarred, it can't reabsorb it.
Yeah.
Then it builds up around the nerve and compresses the nerve and it can't get out because it's scarred
Yeah.
and it's inflamed. I wonder if it's going to work. And that's what we talk about when it's you create a hypothesis. I wonder if, and then you treat as if your hypothesis is true, and then you find out what happens. So I'll let you know next week whether or not we know how to fix Tarlov cysts. And if we do, then there'll be a new section in the advanced next year about how to fix a Tarlov cyst. And it'll be right after the part where we describe what the arachnoid does.
Yeah.
That's why it's different every year.
Yes. Let's get to a couple questions that are up
Oh.
here. And then also that I took a screenshot of something on Facebook that I saw today that I wanted to address.
Okay, let me do Kate's first because it's the easiest one. I have a client that had COVID and has had anxiety attack afterwards. Yes, they are related. Vagus and flu frequencies. Kate, you would get a piece of chocolate if you were within throwing distance. So use the concussion in vagus. Make sure she doesn't have a vestibular thing. Just do fields of gaze. And then concussion in vagus on 1 unit and with a precision care, or you can do it with single frequency combinations because there's 6 viruses with the vagus. And because they each run for a different period of time, you can't run them for 2 minutes apiece, because yesterday with that lady, 3 of the 6 ran for 5 or 6 minutes apiece. And then, so that one's easy.
I'll talk about Leaf's question quickly because it's like one of my favorite controversial subjects is running meth, which is movement, elevation, traction, and heat. The question is, how hot should the heat be? And that really just depends on the patient. Some people do not tolerate hot, and it doesn't need to be hot. Some people like hot, so don't scald them. So we just have towels in the towel warmer that stay at a very safe level. So you could do that. I have patients that use them at home and I just say, wring it under hot water, put it on your wrist. Does it feel good? Then you can put it somewhere else. The thing with heat, with post-op and acute injuries, is that the METH acronym is built as an acronym for a reason, because heat should not just be slapped on and left, because it can do its job and increase cellular response to that localized area. So the reason why we have meth, movement, elevation, traction, and heat, and then after heat, you go back to the M, which is movement. So it should all be used, because when you use heat in the form of demoist heat and you have that kind of inflammatory response, you need to do movement to help vacate the area, work with lymphatics, work with movement. So the whole premise, so that's why we don't see it a ton with post-op when something is immobilized, because you're taking away that movement part. So you just have to be careful with that.
The heat does vasodilation.
Yes.
It increases blood flow, and then you need to increase lymphatic drainage with the elevation and the movement part.
Exactly. Yeah. Macrophages are great. We want them to come to the area. We don't want to hinder that response, but you have to be responsible with that. So the movement and the lymphatic drainage, that's where that traction comes in as well. That can be helpful. So let's talk a little bit. I want to extrapolate on Leaf's thing, but when do you chase scarring in a knee replacement? So I'll let you start with that part.
I've had good success and not good success with knee replacements.
Yeah.
Scarring in the knee replacement has a lot to do with what bled and where. So when you look at a knee replacement, you have to remember that they put a tourniquet up just below your pubic bone. So just on the upper thigh. So there's a tourniquet up there that cuts off the blood supply, and it can cause scarring up in the femoral plexus. When they take apart your knee, they have to stretch it to cut the bones off and insert. They're doing this, and that involves the sciatic nerve, the femoral nerve, the tibial nerves, all of the arteries and blood. You chase scarring in the nerves, the arteries, the veins, and they leave the joint capsule. So after they put in the metal thing, they still put back your own patella and maybe your own bursa if they get lucky, and the joint capsule. And the challenge with the knee, it's better now because they can customize the hardware to match what your old knee was like. 10 years ago, or even 5 years ago, before the customized hardware was being done, the complex curves with the curve on the femoral condyles and the cup on the cups on the tibial plateau where those condyles go, the architecture is incredibly complicated. And so sometimes the scarring, after you've done scarring in the arteries, scarring in the nerves, scarring in the veins, scarring in the whatever, if they still have a hard stop, it's hardware. And then I've had patients where they go into the OR and they want to break up the scar tissue, so they push it past the hard stop. And the only ones I ever see are the ones that don't go well. So maybe it works sometime. You start chasing scar tissue at about 6 or 8 weeks.
Yeah.
That's when I'd stop.
Yeah. And then sometimes it's, are you, like you said, is it scarring? Is that why it's stopping? And this is going to be a really organic, great segue to the Facebook thing that I saw today. Or are they afraid to move it past a certain point because that was the point before the knee replacement that sent them through the roof?
That's a great idea. I hadn't thought about that.
That was what I had about a year or two ago come into the clinic, was saw the person before the knee operation and then saw the patient 6 months after the knee operation when things weren't going well. And it was almost to the letter, to the degree of where she'd stopped pre-op.
Oh, wow.
And I had to get her completely relaxed and sedated on my table so I could passively try to push it a bit. And it easily went past. So it was a moment for 40 and 89
Yeah.
to help.
afraid to move it.
Yeah. So the 40 and 89 that I said this is a very organic segue, and we couldn't have even planned it better, was, and I'm going to paraphrase, but somebody had asked about 4089 caused irritation in a patient, and like they got angry. It was an emotional irritation. And why could that be? And so somebody had written, if 4089 comes with irritation, you should run 81 and 89.
Don't scare me like that.
So I just wanted to address that. And I'm not sure like where it was quoted, but that was what they said, was that should reverse it.
Oh, no.
I'd like you to correct, and you can go on Facebook and correct it later, but let's just talk about that. So 4089 is our safe to move, right? Anybody get irritated with it?
Right. Here's the thing. If you think about what the hip, and I'm having to think about this, and for anybody who hasn't heard the core in a while, I freak out when you talk about running increased secretions in the midbrain, because I made a guy in a coma cry. He had a hypoxic brain injury. He was locked in, which is like being in a coma with your eyes open. He'd moved from a vent to a trach, and he could not blink his eyes in response to command. So it's like being in a coma with your eyes open. And the doc that was involved with his hypoxic brain injury asked me if I would go treat him. So I'm trying to get all of the parts of his brain. So I started at the front, 90, and I did all the basics, increased secretions of vitality. And then I got to the midbrain, and I did the basics and reduce inflammation, then increased secretions, and his eyes filled up with tears. His chin quivered, and tears started running down his face. So I went back and ran 40 and stopped that reaction, and then just did 49 and moved on. So somebody said, why is that a bad thing? And I looked at him and I said, excuse me? When one and only one frequency combination can make a person, male human in a coma cry, that's not okay. So there is no circumstance under which you would want to jack up the amygdala, the hippocampus, and the thalamus. So that's why I freaked out when they said, don't do that.
Yeah.
But let's go back to, why would somebody get angry if you quieted the hippocampus and the amygdala?
So the person had said, it means the thalamus was doing its job. You took it offline and down regulated it. And then it went on to say, when an event occurs, thalamus transmits a signal to the amygdala, small oval structure, important in emotional processing, including emotions such as fear and anger.
Yes, but you have to work backwards from, if you quiet the midbrain,
Yeah.
why would somebody get irritated or angry?
Yeah.
And you have a couple of ways you could go with that. My first response would be 40 and 562 to quiet the sympathetics.
Yeah.
And was it anger, irritation, anxiety? What's the midbrain doing when you quiet the midbrain?
Right.
The amygdala is in the same place.
Mhm.
So it usually quiets emotional hyperreactivity. And what is the midbrain doing in that would make somebody irritated when you quieted it?
Mhm.
What is it? Oh, okay. I know. The hippocampus is in charge of remembering every bad thing that ever happened to you.
Yeah.
So what if in that particular patient, when you quieted the hippocampus, that let something out that was buried? Emotions are never buried dead, they're buried alive.
Mm.
So I would never, like literally would never ever under any circumstance run 81 and 89. But I start pushing buttons and run 970 and 35.
Mhm.
You can also think about the meridians. So we had somebody at the last practicum where there was an acupuncturist. Did I tell the story already?
You did, and I've actually tried it with fantastic results.
Isn't it just amazing?
Yeah.
When we quieted the midbrain at the end of it,
Yeah.
after the meridians and theoretically the energy centers were balanced, then we could. So what if taking the midbrain out of it
Mhm.
released something in a meridian that had been stuck because the midbrain was sitting on it?
Yeah.
You take the midbrain out and energy starts flowing in a way that is appropriate.
Yeah.
Maybe being angry was what needed to happen.
Right.
So the thing I would suggest to practitioners and anybody is to ask, what does that feel like?
Mhm.
I don't know. I just feel irritated. Where do you feel irritated? What do you mean? Open-ended questions.
Yeah.
Tell me what that feels like. Does it remind you of anything? Is it uncomfortable, or does it feel like you just want to go beat somebody up, pound on a pillow?
Yeah.
Ask questions.
Yeah.
Just because we can doesn't mean we should.
This kind of reminded me of the breaker analogy, right? Like it's not about something and then the antidote or the opposite, or it's working your way through the problem as opposed to just flipping to the back of the book and looking for the answer.
That's exactly it. And the other thing is, for the personal growth of the practitioner,
Yeah.
did his anger make you so uncomfortable?
Right.
What were you afraid of?
Yeah.
And maybe it's been a therapist for 10 years, or maybe it's just being 77, but it's what your reaction to the patient's response tells you something about you.
Yeah.
But when you're in the middle of it, it's really hard to think about that. And you think about it, I think about it afterwards. Wait a minute. Why did that make me so jacked up?
Yes.
What was I afraid of?
Yeah.
And for the practitioner, the interpretation was the patient being angry is a bad thing.
Yeah.
And it's not always a bad thing. And it's a good time to ask questions.
Yeah.
So it sounds like there could have been something in the closet that was released or disrupted. Yes, Derek.
Yeah. And I think, and we had talked about this a little bit too, sometimes as patients get better, and I don't know, I didn't read too much of it, but it just really caught my eye and I wanted to talk to you about it because I've never had anybody that felt that with that frequency running. I've had a ton of other frequencies that have brought up, and treatments that have brought up anger and irritation. And I think we had talked about this not too long ago, as especially with car accident patients, I've seen this where they have been stagnant with their progression and then they get better. And so they're super happy. And then they'll come in and then they're mad. They're mad at the time that was lost. How long did this take? Whose fault was it? Why did this happen? And that's nothing to do with your treatment. This is just like and I don't even want to call it a hiccup, but this is just kind of part of the healing trajectory sometimes.
The next book is called Resonance Recoveries.
Yeah.
And I have to do more research, but I'll probably do a teaser at the advance next year or the symposium. And we talk about the stages of grief. They're not cut and dry, they're not set, but there are stages, emotional stages that go with recovery,
Mhm.
especially for FSM practitioners.
Yeah.
because we take somebody that is, it's Katarina says, she's the first to translate the new book. You take somebody that's been stuck, especially with chronic patients,
Yeah.
and they have had no hope. Then they hear that you do this thing. And so they come in tentatively hopeful with their pain at a 6, and they leave at a 1. And there's surprise, there's relief.
Yeah.
Then there's a lot of times anger, but that sometimes shows up later.
Yeah.
And it surprises them, but they're angry at the people that blew them off. They're angry at the people who failed them for 6 years.
Yeah.
Then there's grief over what they lost.
Yeah.
And then there's acceptance, maybe. But we get to help them through each of those stages with concussion in vagus, with quieting the midbrain, with just listening, just being willing to ask the question, now who are you? Who do you want to be now that you've had this for 12 years? You're not the same as you were 12 years ago. Number one, you're 12 years older. And as awful as this was, what did you learn? I didn't learn anything. Wait a minute.
That is a very important thing to bring it back to. One of my favorite new phrases is, and I never say healed because we're never done, we're never finished products, but I'll say, what does the progression of healing look like for you? And then they're like, and it would be, and you can see right away, like the energy just changes. It would, to me, it'd be walking in the park, playing with my grandchildren, going back to pickleball, like whatever that activity is. So to frame it, what would the progression of healing, what does that look like for you? And then
exactly.
So
and that's me asking, who are you now?
Exactly.
But I like your way of putting it better.
Wow.
But what does it look like for you? What would you like to do?
What would you like to do next week? Because we're out of time.
That's what I said. It's like Alpha 357 says, thank you for a podcast. Wait, is it 4:00 already?
Yes.
Okay.
Anyways, yeah, we will be back here, same time, same place next week.
It was really fun.
This is great. It's always great.
It totally
Keep all the great questions coming and
do good things.
Yes. And we get to share about it next week.
Ask questions. Enjoy.
All right.
Bye, sweetie.
See you later.
Later.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.